Okay, so you want to own a hospital, big building, ambulances pulling in, patients walking through the doors every single day, and every one of them needs something you can charge for. Sounds like the most recession-proof business on earth. People get sick in good economies and bad economies. Demand never disappears. It should print money. It does not print money. The median hospital in America right now is running an operating margin of somewhere between negative 0.6% and positive 1.3%. Read that again. The industry that treats the entire country's medical emergencies is, on average, barely breaking even, and in plenty of months, actually losing money. And the story of how a building full of paying patients can still lose money and how an entire town can die when that building closes is one of the strangest, most consequential stories in all of American business. Before you make a single dollar, you need to survive building or buying the thing. A large hospital is not a small purchase. Building one from scratch with operating rooms, imaging equipment, a full emergency department, patient wings, and every code and safety regulation a government inspector can throw at you can run into the hundreds of millions of dollars before a single patient is admitted. Specialized equipment alone, MRI machines, CT scanners, surgical robots, can cost millions of dollars per unit. And unlike a store in a mall, you cannot simply close the doors during a slow season. A hospital runs every hour of every day, whether or not the beds are full. Buying an existing hospital is usually the more common path. And here's where the industry starts looking less like healthcare and more like the mall business than you'd expect. There is a large and growing gap between hospitals that belong to major health systems and hospitals that stand alone, especially in rural areas. The large systems, the ones with a dozen, sometimes 100 or more hospitals under one corporate roof, can spread the risk of any single facility struggling across a much bigger portfolio. A standalone rural hospital has no such cushion. Every bad month happens in full view, with no larger balance sheet to absorb the shock. Now, here's the layer of the business almost nobody outside the industry understands. Hospitals don't really have one customer, they have three, and each one pays a completely different price for the exact same service. The first payer is commercial insurance, private plans through employers. These typically pay the highest reimbursement rates, and the industry has actually seen hospitals benefit from recent rate increases here. This is, in the mall analogy, your full-price specialty tenant paying close to what the service is actually worth. The second payer is public insurance, Medicare and Medicaid. These government programs pay significantly less for the same procedure, the same overnight stay, the same emergency visit. And here's the trend that should worry any hospital owner. More and more of hospital revenue is shifting toward these public payers every single year, which means the average dollar coming in the door is worth less than it used to be, even as costs keep climbing. The third payer is the one that pays the least, or nothing at all, self-pay, and uninsured patients, along with what's called charity care and bad debt. Hospitals are legally required to treat emergencies regardless of ability to pay. That obligation doesn't disappear just because the patient can't cover the bill. Every single one of these visits is, financially, a hole in the floor. This three-payer system is the hospital's version of the anchor tenant discount at the mall. Remember how a department store might pay a tenth of what the small boutique next door pays per square foot, because the mall is really renting the anchor's foot traffic, not its square footage. Hospitals run a similar quiet subsidy. Commercially insured patients effectively help cover the gap left by patients paying government rates or nothing at all. Shift that mix even slightly. More uninsured patients, more Medicaid, fewer commercially insured, and a hospital that looks completely full on paper can bleed cash every single month. And that shift is happening right now across the country in real time. Bad debt is rising. Uninsured volumes are increasing. More revenue is coming from public payers than private ones. Analysts are calling it the industry's new normal, and it's squeezing margins that were already razor thin to begin with. Here's the layer of cost most people never think about, and it's the biggest one by far: labor. Nurses, doctors, technicians, administrative staff. Payroll is the largest expense category in any hospital's budget, and it has been climbing steadily. On top of that, drug costs have been rising by more than 7% year over year, and medical supply costs by nearly 8%. Costs are climbing across the board, and hospitals cannot simply raise prices the way a retail store can, because so much of what they charge is set. Not by them, but by insurance contracts and government reimbursement schedules negotiated years in advance. There's a hidden cost buried inside the billing process itself, and it's shockingly large. Claims get denied, prior authorizations get rejected, paperwork gets lost in a system that runs on enormous administrative complexity. In one recent year, the net revenue hospitals lost to this kind of leakage, money for services they had already provided that simply never got collected, jumped from $38.6 billion to $48.4 billion industry-wide. That's not lost potential revenue. That's money for care that was already delivered, gone, swallowed by paperwork, and denied claims. This is the hospital's version of the mall's co-tenancy trapdoor. The mall looks fully rented on paper until an anchor leaves and triggers a cascade of rent reductions nobody sees coming. The hospital looks fully staffed and fully booked on paper until a wave of denied claims and uncollected bills quietly hollows out the revenue that was supposed to be sitting in the bank. Now here's where the story turns from a business lesson into something much heavier, and it's best understood through what actually happens when a hospital, especially a rural one, shuts its doors for good. Take Parkway Regional Hospital in Fulton, Kentucky. It closed in 2015. The hospital was owned by a large health system that also operated a competing hospital 12 miles away in Martin, Tennessee, and residents with private insurance or the means to travel largely went there instead, including for something as basic and urgent as labor and delivery. The nearest hospital in Kentucky itself sat 22 miles away. For a lot of people, 22 miles doesn't sound dramatic. For someone having a heart attack, it can be the difference between living and dying. This is not an isolated story. Take Van Zant Regional Medical Center in Texas, which closed in August 2019, leaving a county of more than 55,000 people without a hospital, forced to shut down after Medicare cutbacks and low insurance reimbursements made the math impossible. From January 2013 through February 2020 alone, 101 rural hospitals closed across the United States. And after each of those closures, researchers found something specific and measurable. Residents had to travel on average 20 miles farther to access basic health services than they did before, and the number of doctors in these areas declined even faster than in counties that never lost a hospital at all. One healthcare policy expert described what happens next in a phrase that sticks with you. These communities risk becoming paper towns, still on the map, hollow in reality. When a hospital closes, it doesn't just take away emergency care. It eliminates what's often 75 to 100 of the highest paying jobs in the entire county. The school loses enrollment and funding as families with options move elsewhere. The grocery store closes. The gas station follows. Property values decline. Young people leave and don't come back. The people who remain are disproportionately elderly in the exact communities that can least afford to lose their nearest emergency room. And the medical consequences are not abstract either. Researchers at the National Bureau of Economic Research found that rural hospital closures increased mortality from time-sensitive emergencies, heart attacks, strokes, by roughly 10% in the surrounding area. 10% is not a rounding error when you multiply it across hundreds of closures and millions of people. So why does this keep happening over and over, specifically to rural and standalone hospitals? It comes back to that three-payer structure. Rural populations skew older, poorer, and more reliant on Medicare and Medicaid, the lower-paying government programs, with a higher share of uninsured patients on top of that. These hospitals are, structurally, sitting on the worst possible version of the payer mix that determines whether a hospital survives or dies. A large urban health system can offset a struggling rural facility with profits from a thriving surgical center in a wealthy suburb. A standalone rural hospital has nothing to offset it with. When the math turns negative, there's no larger portfolio to absorb the loss. Just a single building, a single balance sheet, and a countdown clock. This is the exact same structural lesson the shopping mall taught us, wearing a different costume. A mall doesn't fail because business is bad everywhere in the building. It fails because one anchor leaves and the co-tenancy clauses trigger a cascade nobody priced in from the start. A hospital doesn't fail because nobody's showing up. Emergency rooms in dying rural counties are often busier than ever. It fails because the mix of who's paying and how much they're paying was never enough to cover what it costs to keep the lights, the operating rooms, and the ambulances running 24 hours a day, every single day of the year, with no ability to simply close early on a slow Tuesday. So does owning a hospital actually work as a business? The honest answer, just like the mall, depends entirely on which hospital and the position you're structurally standing in before you even open the doors. In the optimistic scenario, you're part of a large health system with dozens of facilities, a payer mix weighted toward commercial insurance, strong specialty service lines like surgery and cardiology that carry real margin, and enough scale to negotiate favorable rates with insurers instead of simply accepting whatever Medicare sets. In that world, hospitals genuinely can be durable, profitable businesses, which is exactly why hospital consolidation has accelerated so aggressively in recent years. Bigger systems, fewer independent players, more bargaining power concentrated at the top. In the realistic hard year scenario, the one playing out across rural America right now, you're a standalone facility, dependent on a community with a shrinking population, an aging patient base, and a payer mix tilted toward Medicare, Medicaid, and uncompensated care. Labor costs keep climbing, drug and supply costs keep climbing, reimbursement rates barely move, if they move at all. And when the math finally breaks, it doesn't just take down a business. It takes down the highest paying jobs in the county, the school, the grocery store, and in measurable published peer-reviewed research, it takes down lives that a 20-mile difference in ambulance travel time could have saved. The building isn't really the business, just like the mall. The people depending on what happens inside it are.